about gas exchange. We're going to be talking about ventilation versus diffusion and at-risk populations, thinking about those lifespan considerations and diagnostic tests as well as treatments, and then thinking about how that might apply, for example, of a COPD patient. And we're also going to talk about PE, or pulmonary emboli, as well. Okay, so you'll see I added some pictures here, and that was just as I was thinking yesterday. I was like, this is going to be a lot easier if I pop some pictures in. And, probably didn't have time to really get in too much reading with, having two of those show the professors what thingies this week. So this picture is from your patho textbook for this class, for the reading for this concept for gas exchange. And I think it's really helpful. So we're going to spend some time kind of talking through it and how it all pulls some things together. But when we're talking about gas exchange, right, we're really going to be talking about how oxygen moves and gets transported to cells, and then carbon dioxide, our waste product, gets transported from cells back out of the body, right? And our body needs oxygen, right, for cell metabolism. What did we learn that cells make from oxygen? What's one of the things? ATP, and that's important for that cell metabolism and all of its functions. And then it's going to be removing CO2 as a byproduct. And CO2 will actually, if it's building up in the blood, form acid. And so if I have too much CO2, we're actually going to be making an acidosis forming. And so our bodies use respiration and that ventilation also to help maintain a pH balance and that homeostasis as well for optimal cell functioning. And there's two sides of how this process happens, right? We have ventilation, which that's really getting air in and out of my body, right? That's the breathing. And there's diffusion, which is moving those gases across the membrane at that alveolar junction, as well as at the capillary bed into the cellular junction, right? Okay. So let's first talk about what could happen that could mess with ventilation side. And the nice thing about gas exchange is you guys know it. You've been doing it your whole lives. So you kind of know what normal functioning gas exchange and ventilation looks like, right? You've been doing it. And do you normally consciously think about your breathing? No, it's this unconscious process unless I'm going to take a nice deep cleansing breath or calming breath before an exam, or if I'm sick and I'm starting to feel problems with my breathing, then it becomes more conscious, right? Or I've been playing soccer and I'm feeling out of breath now. It might become more of a conscious process, but otherwise, we really take our breath kind of for granted, right? And that process is regulated by the pons in our medulla, in our brainstem, right? And that has these chemoreceptors that are picking up levels of carbon dioxide in our blood And based off of that, it's able to tell our body, I need to breathe faster. There's too much CO2, right? If there's too much CO2, we're going to increase respiratory rate to get it out. If there's less CO2, we can decrease the respiratory rate because maybe they are hyperventilating and that's too fast. So slow it down. All right. And so that's that primary regulation. And so that's through nerves that send our signals to both the diaphragm, right, and those intercostal muscles to control that respiratory process. So one way ventilation could be impacted is through something that inhibits that normal neural stimulation. Any ideas of things that might do that? Drugs. Yeah, so a drug overdose is one thing that can lower or slow that respiratory response. Or opioids. We might be giving opioids for pain as a nurse. And one of the things they could do is slow a respiratory rate. And so we need to be aware and monitoring that as a potential side effect that we could impact their ventilation and breathing. What else could happen?
Would like a seizure affect?
Yeah, so post-seizure, somebody can be in this post-ictal phase is what we talk about. And so somebody can have just post-seizure a little bit of time where they might pause in their breathing and need some support until that control kicks in. Absolutely. I may have spelled that wrong. How about traumatic brain injury? Something that's going to cause trauma to the brainstem, impact that control. We're going to be worried about it. And then I've got my cervical vertebrae, right? 7 cervical vertebrae. And C3, C4, and C5 are what control the diaphragm. Okay. So this is a repeat after me song. C3. Thank you. C4. C5. Keeps the diaphragm alive. Awesome, thank you. I know that's hard, early in the morning. All right, so, but hopefully it'll help you remember that. But what that means is that somebody has an injury to their spine that is, say, down below at like C7, right? Are C3, 4, or 5 impacted? Or do I still have that pathway from the brain to control the diaphragm? So think about stimulation comes from the brain down. Is it able to follow the pathway out to the diaphragm? Absolutely. We're still okay because the break on the spinal cord is farther down. It's going to impact control of limbs, a little bit lower maybe bladder control, right? But still have diaphragm control. What about if we hit between C4 and C5? I still have C3 and C4. So we still have ability to have that nervous control of the diaphragm. But what if the injury is between C2 and C3? Now, as a nurse, am I going to be worried about that person being able to breathe for themselves? Absolutely, because that signal is going to come down from the brain and it cannot travel farther. So it can't get to C3, C4, or C5, and it cannot get to the diaphragm. So even if that brainstem is like, hey, let's go, it can't travel further down the pathway. So this person is going to need support for their breathing. We're going to need to place them on mechanical ventilation or a ventilator. We might need to bag them until we can do that. Okay, that's out in the field. So that location is important. All right. And not only is it that neural stimulation, it's also mechanics of breathing, right? What if somebody is in a motorcycle accident, they fall, they fracture ribs? They still have that neural stimulation, but is that injury going to impact the mechanics of breathing? Absolutely. So we going to need to worry about ventilation and how good that ventilation is going to be. And could they have gas exchange problems because of it? Absolutely. And so that's a way to think about it. Could be a nervous problem. It could be a mechanics problem, or it could be a little bit of both, depending upon what happens. Now, ventilation can also be impacted by obstruction or restriction of airflow. Bronchoconstriction. What do you think might be an example of that?
Asthma.
Yeah, asthma. Asthma. And that's due to that inflammation, right? Allergic response that causes the muscles in the bronchioles to constrict down and make a smaller airway. Is it going to be more difficult to move air through a smaller hole? Absolutely. If you want to try it, try breathing through your straw. A lot smaller, a lot harder. Okay? And then on top of that, sometimes with inflammatory processes, right, we create mucus. Or that mucus can become thicker and fill in. Right, so maybe this isn't becoming narrower, or maybe it is. And then on top of that, I've also got these secretions. Are those in themselves also narrowing the area that the air can move through? Yeah. And then does suffocation make sense? but that's going to impair ventilation. So all of those would lead to blocked or somehow inhibited or decreased or impaired airflow, right? Feel okay with that side? What questions do you have? Yeah.
So for the C through C4, C5, like as long as you have C4 and C5, you're good. Like if there's a break between
If I've got one of those three,
you just need one of them.
and it depends upon the person, but we need one of those three to still be able to. Yeah. And it may be that initially, because of inflammation, somebody still needs support, but then once the inflammation goes down, then they have enough control, because that inflammation, right? What does inflammation cause? Swelling, pain, but that swelling can put pressure on the nerves coming out of the spinal cord. And so even though the signal's getting down, maybe it's getting pressure put on the nerves coming out from between those vertebrae until that initial inflammation from the injury goes down. And so, again, not always black and white, but we might initially need to help support that person until that initial inflammation comes down, but then there's potential that they can support their own breathing. Yeah, if they've got one of those three. All right. And then we have the diffusion side. I'm going to come back just to make sure you guys can see, because it's a little harder on the blue. Right? Ooh, yeah. How about, is it okay if I turn down the lights? That help? Okay. So diffusion, we are where in the lungs? The alveoli. And those are like the little balloon sacs. They have a very thin membrane. They go right along the capillaries, right? And oxygen is able to move across that junction, and it goes on to what cell? Oxygen binds to hemoglobin on the red blood cell or erythrocytes, and our CO2 is coming back out. And so we need that process to happen. And there's a lot of things that can impact that. And that diffusion is altered by the affinity, the pressures, anything that's going to impact that diffusion principles, right? And so first is through anything that's going to impact the thickness of that alveoli capillary junction. Because I need that nice and thin, close together, for gas exchange to be able to diffuse easily. All right. So one of those can be seen in emphysema. Have you guys heard of that? Who normally gets emphysema? COPD, smokers. So we talk about COPD and then kind of having two different tracks of COPD, emphysema being one. And a huge risk factor or cause of COPD is smoking. It can be exposure to other things, but usually it's toxins, right? And that exposure to the toxins at the cellular level causes inflammation. I told you would not be able to escape it. And in response to inflammation, right, we have swelling. We have the immune response. We have tissue remodeling. Because is that exposure to toxins typically an acute, short, temporary thing? No, it's usually a chronic, long-term over time, and those cells have to adapt and change. And because those tissues are remodeling, that causes fibrosis or scarring. How's the red doing? Is that showing up okay? Okay. And does scar tissue work and act the way the normal tissue normally does? No, it's going to have some issues. It's not going to be as stretchy as that normal alveoli, right? It's going to make that balloon more likely to kind of collapse. All right. And edema, what is edema? Swelling. And that can be through exposure to toxins. It could be from infection, right? Because infection also, how does our body respond to infection? Inflammation, and that inflammatory response. Okay, let's look and I'm going to show you kind of what that looks like over here. All right, so on the left, this is kind of what normal looks like, right? We have alveoli. Air comes in from the bronchioles. It fills that space. And we have a capillary bed with all our blood cells moving through. And my O2, right, is able to easily diffuse. See how close that is across. And my CO2 is able to move back out. And when I exhale, it's able to leave my body. So I don't have acid building up. And there's a video about this process for those of you that like to see how it goes in your pre-class videos. Okay. Versus on the right is what's happening with inflammation. Right? That capillary bed becomes leaky. So I have fluid coming into that extracellular space, which creates more space in between the alveoli membrane and the capillary membrane, which makes it harder for that O2 and CO2 to move between the two. That's that swelling or edema. And then in response, right, I have all of my immune system cells coming and trying to fight whatever's going on, the toxins or the infections, right? And if this is happening chronically, long-term time, we tend to have tissue remodeling. And this membrane here is going to become scarred and thicker, which makes it, again, even harder for the gases to move across the membrane. It also is going to make the alveoli harder to have that surface tension, more likely to collapse, which then I lose those alveoli. So I have less opportunities for that gas exchange to happen. And the ones I do have are thicker and scarred. Okay. So a lot of these should look kind of familiar, right? We have our fibrin and our platelets that are kind of sticking to the walls. We have our tissue factors. And then NETs is actually neutrophils, extracellular traps, and they build them to trap bacteria and viruses. Okay. So that's what we're talking about here. Other things that could happen are things that would change that parcel pressure that helps with that gas diffusion principles. Any ideas what that could be? Okay. So, have you ever heard of the oxyhemoglobin association dissociation curve? Or maybe you hoped you hadn't because you didn't want to learn it. So basically, we have our PO2, so that's the pressure of oxygen. And then we have our oxyhemoglobin. That's like the affinity on the hemoglobin, right? And then as those change, how it's going to bind. So it's like, how likely is it going to move from one space to the other to want to connect to the hemoglobin on the red blood cell? All right? And there's a couple different factors that are going to make it either less likely or more likely to do that. Things that are going to make it more likely to shift to the left, which means it makes the hemoglobin stickier. And so it wants to hold on to that oxygen. And so it's going to pick it up in the lungs, but it's not going to want to let it go at the cells when it gets out to my cells. All right. Things that will make it stickier are hypothermia, alkalosis. What's alkalosis? Basic. What's normal pH? 7.35 to 7.45. So alkalosis would be less than, greater than 7.45. We can also see it because severe vomiting, hyperventilation are going to cause alkalosis. That might be where you'd see it. So hyperventilation, severe vomiting, dehydration. Has anybody ever done a polar plunge? All right, you're brave. Okay, so when you got in the water, super cold, right? When you got back out of the water, were you like clinging to your towel or blanket? Or before you got in, were you clinging to your towel or blanket? Okay, that's the best example I could come up with. You were like hemoglobin and oxygen clinging together because it was so cold. All right, so hypothermic, stickier, it's going to hold on to the oxygen, not want to let it go at the cellular level. Okay. And so what we see is this shifts to look more like this. Okay. versus we can have it shift to the right. If it was hypothermic for 1, what do you think is going to happen to shift right? Too hot, so fever. If it was alkalosis, what do you think? Acidosis. And so pH less than 7.35. And we can see this with hypercapnia. Do you guys know what hypercapnia is? That is high CO2 in the blood. Somebody who is exercising to the extreme, right? And that means that hemoglobin is going to be like, let go, let go, let go of that oxygen, right? Because the cells need it so badly. Harder uptake, easier letting go, okay? We also see changes with high altitude. And it's not because there's a different amount of oxygen in the air, it's because of the barometric pressure that adjusts how that oxygen is going to move across the alveolar membrane, okay? And then I was trying to get pulmonary embolism on here, and it really doesn't, it's not really because of a partial pressure. It's not really because of thickness, but it is because of how the blood flow is impacted, right? And so I'm going to put it down here. It's blocked transfer of O2 to circulation, and it's because it's a clot in the blood flow in the lung that's blocking blood flow, right? So if there's a clot right here, can the blood come through to have any gas exchange happen? No. So it's going to impact diffusion. I can ventilate, but it's going to impact diffusion because there's no blood flow from that clot. So it's not really because of the thickness, it's not really because of partial pressure, it's a blood flow issue. So it's kind of living in that side but doesn't really have a happy space in there, okay? And any of those things, ventilation, diffusion, or a flow issue can cause hypoxemia, hypoxia, what's that? Yeah, low O2. And we're really saying hypoxemia, that's in the blood, hypoxia at the cellular level. I have a lack of it. Versus hypercapnia. Remember what we said? Increased CO2. Okay. And that because CO2 creates what? Acid. It leads to acidosis. And acidosis leads to cell death. And cell death leads to tissue death, which leads to organ death, which leads to death. Okay. So we really need ventilation and diffusion to support life. How are you feeling? A lot more than what you thought was going to happen in one picture, right? Okay. Hopefully, you'll see how it kind of helps pull it all together. All right. So we talked about the chemoreceptors, right? We have our brainstem. And what chemoreceptor is it picking up? That's then controlling I breathe faster or slower. CO2. And so that's kind of your number one mechanism to control the rate of breathing. But we also have a backup system. You're going to see in God's design, our body has a lot of backup systems just in case one thing fails. We got a backup, right? Because it's all about maintaining that homeostasis. And we got to back up until our bodies can kind of adapt and get number one back in working order, all right? And so that is our peripheral chemoreceptors. And they are located in the carotid and aortic arch. What's that close to? Yeah. And that's coming right off of our lungs, right? As circulation goes through. And so that is actually not going to be measuring CO2. That's going to be measuring O2 for these chemoreceptors. Okay. And so for number one, it's looking to say, okay, when CO2 is going up, I need to increase my work of breathing. Versus my peripheral, when O2 is going down, we need to speed up our work of breathing. So they're kind of opposite. All right. Have you ever seen somebody that was struggling to breathe, not getting good gas exchange? I'm going to turn the lights back on now. We got through that. These hard colors. Anybody work as a CNA? Maybe seen somebody come in respiratory distress? What do they look like? Hey man, I don't feel good. Hard time breathing. No? Or, it's not good. I don't feel good. It's horrible. Right? Okay. So, what are we going to see first? And we have symptoms of hypoxia, low oxygen, symptoms of hypercapnia. And we have our early signs versus later signs. So we're going to start by talking about what's going to be happening earlier, right? And really early on, somebody's going to start getting really restless and anxious. Just kind of, something's not right. I don't feel right. I'm maybe kind of confused. They start answering a little funny or just kind of a little drowsy, right? Another early sign can be a headache. And then later on, we're starting to see that rapid heart rate, faster breathing, and I feel like I'm having a harder time breathing. So interesting enough, those more specific signs that we might think, this is what somebody having a hard time breathing looks like. Somebody is just restless or kind of confused, right? Those can be the earlier signs. I mean, we're week 4. I think you kind of know I'm kind of chill, right? And if you came in and I was just like, guys, What's going on? We need to go somewhere. What's going on? Like, you'd be like, okay, something's different with Carrie today, right? And I might be acting a little anxious or a little restless or confused in that moment. And that could be a sign that maybe my brain's not getting enough oxygen. Okay. Versus later signs, we can see more extreme restlessness, right? That heart rate goes from being tachycardic, and you guys you've seen with Essentials tachycardic, tachypnic, comfortable with? Okay, just want to make sure. That bradycardia, slower heart rate. Why do you think that is? Why does that show up later? Yeah, I'm running out of oxygen and I need O2 to make ATP. And ATP is important for what on my cellular membrane? Sodium, potassium channels. And those sodium, potassium channels are really important for like muscle contraction and nerves stimulating. And that's all needed for my heart to beat, right? So that's a sign of that switching anaerobic metabolism, okay? So extreme restlessness, and then you might start seeing some blue skin or cyanosis. And we tend to see that first centrally, so you might see it lips, mucous membranes, before you start seeing it on somebody's fingers. And I'm going to tell you, for somebody with darker skin, it's a lot harder to notice, and you are more likely to notice it with lips than trying to see it on somebody's fingers. Okay? So I worked in a doctor's office as one of my first jobs out of nursing school. And we would see patients and bring them back. And then one day, one of the front office staff came and they're like, somebody's out here. They said their friend's in the car. They need help. Like, can you come check them out? So I walk out, and his friend he was driving him in for his appointment, and they're like, they just need some help coming in. And I go out to help him in from the car, and he's sitting in the driver's seat, and he's leaning forward like this. Okay, what am I seeing first? What's this? Tachypnic, fast breathing. All right. He's kind of looking around like this. What that might that be? Restlessness or anxiousness, yeah. And I see around his lips is not just purple, it's gray. Do you think I helped him in for his appointment? I also saw in the back seat this little guy, which was not hooked up to a nasal cannula on his face. It was just hanging out because they brought it along for when he got there, but he hadn't been wearing it the entire drive-in. But what's this? An oxygen canister. And so I looked at him and I looked at his buddy. And I said, I am very concerned. And the hospital is right there. And I need you to drive to the emergency department. Why?
Because he couldn't breathe?
Yeah.
Because it was an emergency?
And it wasn't just early signs of an oxygen problem. It was late signs. right? He was completely gray. And so it was like, where's your nasal cannula? Can we turn this on and keep driving? It's like literally 2 minutes, like less than 2 minutes right there. I need you to pull in right there because you need way more help than I can do in this outpatient clinic to get the care you need, right? Okay. Versus hypercapnia, which is what? Too much CO2. What do you notice about the symptoms? What's happening? Respiratory. Shortness of breath, we might also call that. Dyspnea. All right. How about heart rate? Tachycardia. They might be sweating. And they might be kind of shaky. How about up here with central, and this is kind of talking about central nervous system. Drowsiness, kind of sleepy or falling asleep, dizzy, confused, headache. And then are most of these pretty similar to signs of early hypoxia? Yeah, pretty similar. I will say the one thing that tends to be different with hypercapnia is this sleepiness to, as it gets pretty extreme, they can even be completely unconscious or not responding well because of that acid accumulating, right? So a brain on acid is confused and really sleepy. And if it's really bad, they're snoring, you're like, hey, and they're versus, okay, my extremely hypercapnic person is just, okay? That's gonna be my big difference there. Questions about our symptoms? Tracking okay. All right. Let me just stop. So if you need stretch, move around. You can stretch for a while.
Comes in a tidal rush, a breath of life, a gentle push. That's ventilation, clear the track for diaphragm and muscles act. The chest expands, the pressure drops, the oxygen fills up the stops. But asthma's grip, a tightened chest, or COPD puts lungs to the test. The airways narrow, filled with dread. The vital, easy breath has fled. The work of breathing starts to climb, stealing comfort, stealing time. The body's frantic, urgent plea when O2 drops for all to see. Confusion clouds a worried mind, a gasp for air you cannot find. A rising sense of anxious pride, a struggle just to make it right. The heart beats fast, tachycardia's race, tachypnea sets a hurried pace. That shortness of breath, the dyspnea deep, promises the body cannot keep. Don't fast. Diffusion is the silent trade. A life for waste exchange is made from alveoli rich and deep. O2 will jump a vital leap into the blood, a willing ride, while CO2 is swept aside. But fluid builds pneumonia's plight. Of fibrosis scars turn day to night. The wall gets thick, the path is blocked. The precious simple trade is marked. The oxygen is left behind, a crucial piece you cannot find. Oh, the body's frantic, urgent plea when O2 drops for all to see. Confusion clouds the worried mind, a gasp for air you cannot find. A rising sense of anxious pride, a struggle just to make it right. The heart beats fast, tachycardia's race, tachypnea sets a hurried pace. That shortness of breath, the dyspnea deep, promises the body cannot keep. Don't wait till the pulse begins to fade. A bradycardia serenade or restlessness turns to weary sighs, and cyanosis paints the lips and dies. Those late bad signs, the final cry. Now in the stream, a crimson flow, the hemoglobin starts to glow. The transport system strong and vast, a cellular and vital cast. Each molecule of O2 bound, delivered to the body's ground. From head to toe, the cells await the fuel to seal their living fate. But with anemia, cells are few, the oxygen can't make it through. Or poison gas in pale disguise binds hemoglobin, tells it lies. The tissues starve, they start to fail behind a healthy looking veil. Frantic, urgent plea when O2 drops for all to see. Confusion clouds the worried mind, a gasp for air you cannot find. A rising sense of anxious pride, a struggle just to make it right. The heart beats fast, tachycardia's race, tachypnea sets a hurried pace. That shortness of breath, the dyspnea deep, promises the body cannot keep. Don't wait till the pulse begins to fade. A bradycardia serenade or restlessness turns to weary sighs, and cyanosis paints the lips and dies. Those late bad signs, the final
Different
cry.
ways gas exchange is impacted and the symptoms. Okay. So, who's at risk, right? What are some of the populations you have learned about? Maybe risk factors, lifestyle things that might impact gas exchange. Smoking, yeah, huge. Why? Yeah, because of the exposure to toxins and carcinogens, right? And so we have that inflammatory response going on that's going to impact in the bronchioles and the alveoli, impact airway for ventilation, also impact diffusion at that alveolar membrane. And then carcinogens can also impact the cells, cause tumors to form in cancer. Okay. How about this little one down here? So looks like probably born prematurely, right? So with that, we have risk that lungs have not formed. And so our lungs need surfactant to help with, any ideas? Surface tension on the alveoli. So it helps them stay expanded without enough surfactant, alveoli are going to collapse. And it also helps them kind of slide around against each other and not be damaged. So baby born prematurely, we worry about surfactant. If we know that somebody's having risk for premature labor, maybe early contractions, we can give steroids to help kind of speed that development along. For me, my kids are 2 preemies, and one was kind of out of the blue, and so she was kind of looked like this on a CPAP in NICU for several weeks, and really, like, from labor started to when I had her was about 6 hours, and so we didn't really have time to get steroids in and be able to impact, and it's really like 35 weeks and before where we're going to worry about that surfactant deficiency, versus within my second pregnancy, knew I was higher risk and started having contractions and issues at like 24 weeks. And so able to do a couple doses of steroids early on. And she was born at 33 weeks. He was born at 35, but actually did incredibly well. And I think those steroids were a big part of that for his lungs. Okay. How about in kids? What's maybe a big issue we see? Yeah, asthma, allergies. As eustachian tubes are developing too, they at first are fairly parallel draining into the back of the throat, and then as we grow, they angle down and things drain better, and so that can put somebody at higher risk for ear infections, and that kind of all goes into upper respiratory infections and higher risk. So, but that constriction of the bronchioles, inflammation, definitely higher risk there. How about for our older population? So if somebody has bed rest and mobility, can impact taking deep breaths, may have weaker muscles for being able to take those breaths, or the clearing of any mucus is one factor. Also thinking about aspiration risk. So if somebody's neurological status is impacted, maybe post-stroke, then they have an increased risk for aspiration. What's aspiration?
Suffocating on your own secretions.
Yeah, kind of instead of swallowing my own secretions, or when I swallow food and it going down the proper pipe and not into my lungs and into my stomach, either my own saliva can go into my lungs, or when I take a sip of water, rather than going down to my stomach, like somebody takes a sip of water and you hear them go immediately, that could be a sign that it's going straight towards those lungs and they're having a hard time clearing that, and they might be having a risk of aspiration, especially if somebody's post-surgery, post a stroke, and you give them a sip of water and then they start coughing. Be thinking about, are they aspirating maybe? Okay. And then there's also chronic diseases. Such as like cystic fibrosis. Cystic fibrosis impacts mucus production throughout the body, GI tract, pancreas, and in the lungs. And so it makes it really, really thick and sticky, harder to clear, and higher risk for infections. So higher risk for gas exchange issues there. Also, if somebody has chronic obstructive pulmonary disease, maybe from exposure to smoking, or maybe their job, they worked in a factory, could then over time they have that decreased function, right? And then also our patients with heart failure are going to have gas exchange issues. And I'm going to come back to that next week. We're going to talk about it. Heart failure here. So why does somebody with heart failure have issues with gas exchange? Because my heart is my blood flow. That's a perfusion thing, right? What's going on? Why am I worried about gas exchange? Any thoughts? Yeah, so it's making my heart work harder. And so let's look at this side first for diastolic. So the chambers become stiff, right? And what do you notice about that left side of the heart compared to the right? Smaller, yeah. Okay, so this is my little person. Losing battery. So as blood flow, and then we're gonna make some happy little lungs here around my heart, right? So blood flow comes into the heart, goes out to the lungs, comes in. As it's coming in from the lungs, can the same volume that was just pumped out from that right side make it into the left side? No. And so we are actually going to start getting this buildup of blood within the blood vessels in the lungs because of that. It's called pulmonary congestion because it's kind of backing up. We can have fluid kind of leaking in. And so they get fluid overloaded in the lungs, which then makes it harder for that blood to move through, puts pressure on the alveoli, and can cause breathing issues. All right. Versus systolic, we're really stretched out, really stretched out, thin, weak walls. They're going to have a hard time squeezing and pumping. Right? With this, you're going to tend to see back up, and we can have it backing up in the lungs. We can also have it backing up peripherally, and so this is where my person starts having swelling in the ankles, swelling in the feet. Because blood's not moving very fast, I have low output, I can have issues with getting blood flow to the cells, impacting that diffusion at the cellular level. Okay.